All right, so now for our second speaker, I'm pleased to that Linda Niccolai is here to present her research in HPV vaccination. She's an expert in this topic area. Linda's been at Yale now in the School of Public Health. She's an associate professor. She's been here for about 15 years, and she did her training at Harvard and Tulane in epidemiology. So welcome.
Okay, thanks. Melinda, thank you all for coming. So as Melinda said, today I'm going to talk about HPV vaccination and the important role that clinicians play in promoting higher uptake. So we currently have 3 vaccines that are licensed for use in the U.S. that can prevent infection with human papillomavirus. We have, the first one was Gardasil, the quadrivalent vaccine that was licensed in 2006. Then in 2009, the bivalent vaccine, Cervarix, was approved, and most recently, at the end of 2014, Gardasil 9, or the 9-valent vaccine, was licensed for use. And so all 3 of these vaccines prevent different combinations of the various infecting types of HPV that can cause 6 types of cancer and genital warts. So the vaccine we should be using now, the 9-valent vaccine, has the potential to prevent up to 90% of all cases of genital warts and between 80-85% of cases of cervical cancer. So really exciting. Current recommendations are for routine immunization for all girls and boys at ages 11 or 12. For kids who are not immunized at 11 or 12, the recommendation is to immunize girls up to age 26 and boys up to age 21, and it's a 3-dose series to be given over 6 months. Sorry. So these are really good vaccines. They're very safe and they're very effective. So the pre-licensure, the pivotal pre-licensure randomized trials that were done with tens of thousands of women around the world showed that the vaccines are over 95% effective in preventing vaccine-type infections when given to people who've not previously been exposed. And I think it's notable that not all vaccines work that well, so it's a really good vaccine. We also have lots of data now around safety. Clearly they were safe in the pre-licensure trials, and now we have a variety of different efforts, post-licensure marketing, being done by CDC, FDA, the drug manufacturers, and academic researchers, showing no serious adverse events linked to HPV vaccines. And we can note that over 70 million doses have been distributed in the US, so 10 years of accumulating evidence that the vaccines do not cause harm. And it's also worth noting that these vaccines have a very similar safety profile to other vaccines that we routinely give our kids all the time. So they're safe and effective. This is really exciting news for those of us working in the field. There is growing evidence that these vaccines, we know they're effective from the clinical trials, but now we're able to monitor post-licensure population-level impacts on reducing HPV-associated diseases, and we're seeing really remarkable declines in a variety of different outcomes associated with HPV infection. So in the US, and there's a whole global body of literature on this topic, I'm just going to focus on the US. For example, we're seeing 64% decline in HPV infections in young women, adolescent females, and 34% decline among women ages 20 to 24. So we're really cutting the number of HPV infections, by half in young women. Genital warts have declined by 35% in young women and by nearly 20% in young men. We think there's some herd immunity going on there. And what's really exciting to me is work that we've been involved in Connecticut since about 2008 is looking at the impact of vaccines on precancerous cervical lesions, so cervical intraepithelial neoplasia grades 2 and 3 and adenocarcinoma in situ. So these are really clinically very important outcomes, right, because of the associated morbidity, psychological impacts, and treatment costs. And we're seeing in Connecticut up to 55% declines in precancerous high-grade cervical lesions in young women. So the vaccines are having a real impact on population health. So that's the good news. The bad news is that uptake of these vaccines, coverage with human papillomavirus vaccines, is, I would say, unacceptably low. So this slide shows national data for coverage since 2006 with the 3 vaccines that have the same recommendations. So meningococcal conjugate vaccine, Tdap, and HPV are all recommended for routine use at ages 11, 12, and can be given at the same well-child visit. So same recommendation, can be given concurrently. They've all been recommended since around 2006. And you can see from the figure that we're doing much worse with HPV than we are with the others. So we've achieved 87% coverage with Tdap, 79% coverage with meningococcal conjugate vaccine. But for some reason, or for many reasons actually, you can see we're doing much worse with HPV. So we've achieved 60% coverage with at least one dose in females, and only 40% of females have completed the 3-dose series. We're doing even worse for boys. 40% of adolescent boys ages 13 to 17 have had at least one dose, and only 20% have completed the series. So this is a problem. So why is this? There are a lot of reasons, but I think many of us working in the field would now agree that a key barrier, if not the key barrier, right, the reason why coverage for HPV vaccination is lower than for the other vaccines is because of a lack of strong recommendations from clinicians. Any study that has looked at this has pretty much come to the same conclusion. There's a variety of studies, a real growing body of literature, that physicians not giving strong recommendations is a very significant predictor of kids not being immunized. So at the end of 2015, a study came out, this is the national data, that middle bullet, where clinicians themselves reported 59% of them do not recommend HPV vaccine consistently, 49% do not recommend it urgently, and 27% said they do not recommend it strongly. So clinicians themselves are saying we're not making these recommendations consistently, urgently, or strongly. We have some local data. So I was involved in a research project a couple years ago where we talked to parents. These are parents who bring their kids to Yale New Haven for their primary care, the primary care center. And we asked the parents to reflect on their experiences with HPV vaccine. And this is a quote that's very typical of what we heard. So this is a parent talking about her experience. And she said the clinicians, explained to her what the shot was for, and that if she didn't want to get it, if she didn't want it, she didn't have to get it. So it's really being presented as optional. You don't need it, you can do it, but you don't have to. And I honestly can't think of another vaccine that's routinely recommended where people are being given this option to immunize their kids. So this is what we have decided to focus our work on. So what I'm going to do now is share with you results of a study that we recently did just last year, and we're still working on it a little bit, but we decided, so it was clearly documented that clinicians aren't making strong recommendations, and that's an important predictor of uptake. What we wanted to really do was deepen our understanding of why clinicians are not making stronger recommendations, right? So what is the motivation? What are the reasons for this behavior that's really keeping uptake low? So we did a qualitative research study, which really we needed to do. So qualitative methods are really useful. I don't know if people are familiar with qualitative research, but it's really useful when you want to deepen your understanding or really understand better a particular behavior or phenomenon. So what we do is we do interviews with participants. In this case, we did it with clinicians. And we ask them in their own words to describe their experiences. So it's a semi-structured interview with open-ended questions. We let the clinicians just tell us what their thoughts and allow them to reflect on their experiences. And from that, we can derive deeper meaning and a deeper understanding of the behaviors. So we interviewed 32 clinicians in 6 of the 8 counties in Connecticut during 2015. We did medical doctors and advanced practice nurses trained in pediatrics and family medicine from both private practices and public clinics. What we do is we do these unstructured interviews. We audio record the interviews. We transcribe those interviews, and then those transcripts, that narrative, is our data that we analyze. So then we use an iterative thematic content analysis approach to see what themes emerged from the data. And this was work we did. We were funded by an NCI supplemental grant to the Yale Cancer Center, so I thank the Cancer Center for that opportunity. So first, it's important to note that many providers are enthusiastic supporters of vaccination, and that's why we have 60% coverage, right? There are many providers out there who are doing a great job of immunizing their patients. What we're focused on is sort of that 40%, right? Who are the people that are not and how come? So in this sort of population of people who are not enthusiastic supporters of the vaccine, challenges that emerged, reasons why clinicians said they were hesitant or reluctant or unable to make strong recommendations include this perception of a need for an in-depth discussion about HPV vaccination, their own gaps in knowledge about safety and effectiveness, and discomfort discussing sexuality. So what I'm going to do now in the next 10 minutes. On the next slide, so these are the themes that emerged from the data when we did our thematic analysis. So then what we do in qualitative research is we go back to the transcripts and we identify quotes that are illustrative of the themes that we identified. So what I'm going to show on the next series of slides are actual quotes from clinicians in our study that support each of these themes. So the perceived need for in-depth discussion. So here's what one clinician said. It's a pain in the neck spending 5 minutes of a 15 or 20-minute visit just on vaccines, and therefore perhaps not talking about social media safety or texting while driving or other things. So, right, the annual well-child visit is 15 or 20 minutes. It goes fast. There's a lot to do, and there may be competing priorities. So this idea that it might take 5 minutes to just talk about vaccines was viewed as a competing priority. So why did they think it would take 5 minutes to talk about vaccines? One of the things that emerged is clinicians really felt the need to address exposure to misinformation, right? That parents come in with this misinformation about the vaccine, and it might take 5 minutes to address that. So for example, another quote from a clinician. They're always reading these negative things about HPV in the media. They come to the visit with a very negative view of the vaccine. You have to spend a lot of time convincing them that it is safe. I dread it because parents have all kinds of crazy information. And finally, there seems to be some public information out there which many people ask me every single time, is this safe? I don't get that anymore from the other ones. So again, these are all clinicians talking about why they perceive it takes too much time to talk about the vaccine. And I think that last quote, I particularly like that one because it raises another issue, which is how HPV vaccine has really been treated differently than all other vaccines. The rollout of this vaccine, the way it's been rolled out over the past 10 years has been really unique in history. It's really been treated as exceptional somehow. So HPV being what it is, don't have time to go into all of the reasons for the unfortunate rollout, but that there's this misinformation. Another reason why clinicians feel it's going to take them too long to talk about HPV vaccine, again, that 5 minutes, is because we do not currently in Connecticut have a school entry requirement. So Tdap and meningococcal vaccines are required for kids to go to school. HPV is not. That's a whole nother topic of conversation for another day, but here's a quote from a clinician. For HPV, because it's not a mandated vaccine, it tends to involve more of a discussion. Another clinician, when kids need it to get into school, it's not a discussion. So what we hear clinicians say is, okay, meningococcal Tdap, we're going to do these today, your kid needs them for school, and then there's this other vaccine, HPV, and you don't need it for school, it's more optional, and presenting it that way, again, somehow different, really gives parents more opportunity, more leeway to opt out. So clinicians have this perception that it's just easier if you can tell people they have to do it, and that's not the case for HPV vaccine. So moving on to lack of data about safety. So again, I've said it before, I'll say it again, how HPV is being treated differently. So I'll read the quote and then I'll explain. So measles, mumps, rubella vaccine had the unfortunate incident many years ago where it was linked to autism. That study was subsequently retracted. Completely not true, but here's the quote. At least with MMR and those scares with autism, I can say, hey, that guy was refuted, he lost his medical license. I don't have anything other than what's out there for HPV that shows it's safe. So again, MMR, we can now say it doesn't cause autism, okay? But for no other vaccine do we have something like, hey, that guy was refuted. All vaccines are subject to the same post-licensure monitoring. So if the other vaccines are safe, I don't know why we think we don't have data that show that HPV is safe. Clinicians have their own questions about the long-term effectiveness of HPV vaccines. So here's the quote. So we have to tell them that it theoretically will prevent or reduce the risk of a variety of cancers, but there's no actual data on that yet. So that's true, because the cancer outcomes happen many, many years after the HPV infection. So we do not know, right, about the reduction in cancers. But I would say two things. One is we have all that other data I showed you on reductions in precancerous lesions and warts and other things. So there are data that the vaccines are impactful. And again, other vaccines are licensed and recommended based on efficacy from randomized trials. We don't wait for population level impact for the other vaccines to start recommending them strongly. that I'm aware of. And this is something very interesting. So clinicians, and we hear this, we've heard this more than once, we do hear, I cannot find out how long the immunity lasts for. If it's only 5 years, I don't want to give it to a 12-year-old. I want to sort of push it out as late as I can. The idea here that the vaccines are recommended at 11, 12, we're hoping to prevent an infection that people might get in their 20s or 30s, to prevent cancers they might get in their 30s or 40s. And there's this concern that immunity might wane by the time people are naturally exposed to HPV through sexual behaviors. We actually currently do have really good data. The immune response to these vaccines is very robust. It appears very durable. People have been followed for up to 10 years, which is all we currently have because we've only had the vaccines for 10 years. And the immune response appears very robust. It's being monitored. If it ever were to wane, we would know that. And we've seen that for other vaccines. So like varicella vaccine, we observed waning immunity. So now we recommend a booster. So what we currently know is immunity lasts. If it ever did wane to the point where people would need a booster, we'll know that. But clinicians aren't reassured about that. Just a couple more slides with the quotes. So this is, I always pause because I'm so troubled by this. So the clinicians, right? Medical doctors and APRNs practicing in Connecticut have questions about the effectiveness for boys. So we know these vaccines prevent genital warts in boys. We know they can prevent anal and penile lesions. And in theory, they should prevent oral pharyngeal cancers down the line. But we hear clinicians say things like, I don't think it's really necessary for boys. It is recommended, and we do have data that boys benefit, but I mean, I guess it speaks for itself. And one other quote, I'm going to have to be frank with the parents that we're doing it merely to protect the girls rather than the boys. So the idea if we immunize the boys, we protect the girls, and while that's true, I think clinicians need to remember that there is a direct benefit to boys from this vaccine. And then my last slide with the quotes, Discomfort, discussing sexuality because HPV is sexually transmitted. Some clinicians are reluctant to, or uncomfortable talking about that. So this quote, you try not to trip over your words. You try to explain this is just, you want to give it well ahead of time. You can usually catch yourself tripping over your words. So I do love this quote because this clinician is tripping over their words talking about, like they can't even talk about sex. So this is a problem. Okay, so those are my quotes, couple of just conclusions, and then I'll wrap up. So I think these data point to some really important educational needs for clinicians. I'm not a clinician, so, but I do think, many of us think, well, the truth is that clinicians are people too, and their knowledge is not perfect. They don't know everything we would like them to know, and they can't, right? There's just too much going on. But safety is important. Parents come in and have questions about safety. Clinicians need to be able to address that, okay? So saying we don't have good safety data is not an appropriate way to have that conversation with the parents. So clinicians need to be prepared to talk about safety. Clinicians need to be mindful these vaccines are having an impact. And I think we can do a better job of disseminating our research around population-level declines to pediatricians and other clinicians who see children. Clinicians need to know we shouldn't be worried about immunogenicity. We don't worry about that for other vaccines either. Hepatitis B is another great example. That the immunogenicity is good. And the rationale for boys, clinicians just need to know that we should be immunizing all our boys in the same way we're immunizing all of our girls. So I think educating clinicians about these things can help them have more appropriate conversations with their patients. Another thing that I think would be very helpful is more of a bundled approach to recommending HPV vaccine with the other vaccines. So there are 3 vaccines, they're all recommended, safe and effective. They're all due at your child's visit today. I'm going to give your child all 3 vaccines. Do you have any questions? And there's really no need to single out HPV because it's a sexually transmitted infection. We should be focused on the cancer outcome. There's really no need to single out. It's not required for school. Really, I would ask clinicians, why are you immunizing your patients, right? Is it so they can go to school or is it to prevent disease? If it's to prevent disease, keep the focus on that message and don't worry about the school requirement. And finally, recommendations at ages 11, 12. So we're unfortunately relying a little too much on immunizing kids in that catch-up age range, and we're not doing a really good job at 11, 12. I think if we did a better job of recommending this vaccine at 11, 12, it would take care of a couple things. One is it would reduce competing priorities. So that quote around, oh, I have to talk about alcohol and drugs and texting while driving, those are less relevant at 11, 12. So if you wait until your patient's 15, then yes, you might have more competing priorities. At the 11, 12-year visit, you can just say 3 shots today and move on. And it would also reduce the need for discussion about sex. At 11, 12, that's not something that needs to be brought up. But again, at 15, 16, it becomes more salient. So if we could do a better job of just doing it at the recommended ages, I think it would take care of some of these challenges as well. So moving forward, this is my last slide. So I think we know enough about what the challenges are, and now it's really time to do something about it to bring that uptake higher. So we have an idea to develop a mobile application or an app that could be used on tablets in clinical settings to provide information to patients about it's called the Adolescent Platform, about all 3 vaccines in an interactive and tailored way. So there's a couple features of this app we have envisioned that we think would be good. First is all 3 are going to be bundled. It's not going to be an app for HPV because that's treating it differently. It's singling it out. It's, why are you telling me so much about HPV? Gives parents pause, right? So if we just bundle all 3, wrap it up, we should be fine. And what we really hope this app will do is, in one sense, it will be educating parents about all 3 vaccines in a bundled way, but we also hope that it will facilitate communication with the clinicians. It will take some of the burden off clinicians to have these time-consuming, uncomfortable discussions if parents can read about the vaccines in an app and then just ask questions about whatever they may have questions about. So we're hoping to develop this app this summer and see if we can't get coverage a little bit higher. So Anna North is in the audience. She's been a key member of my research team, and she did most of these interviews, as Caitlin Hansen, a pediatric infectious disease fellow, and members of the working group at Yale. Dell is here, and I don't know if Cheryl, Jean, or Dan are here, but I want to thank everybody who's contributed to this work. Sorry.
Time for a couple questions.
I'm curious as to how much feedback, pushback you get from the recipients, from the other side, the mothers, say, or fathers, in terms of both the stuff out there about autism and vaccines, and also whether some people are saying, hey, you're enabling the argument you heard about birth control pills.
Right, so the question, generally speaking, is one about pushback from the parents around things like autism and things like that. So I think, one thing I've learned, and it's not groundbreaking, but is that parents generally want to do the right thing for their children, right? They want to protect their health and promote their well-being, and parents generally want to do the right thing. I think what we're really seeing a lot of is what we call vaccine hesitancy. There are a small number of people who will absolutely refuse all vaccines, right? The anti-vaxxers, they're sort of called. But that's actually, it's a very vocal group, but a very small group. A much larger group of people are folks who have questions and concerns. They want to do the right thing, but they heard something or they saw something. So this comes back to the whole premise of this talk, the role of clinicians. Parents overwhelmingly say they trust their doctors, right? Very trusted source of information. So parents, if you buy that a very small number of them actually are going to refuse, most of them want to do the right thing, they do have questions, and they trust their clinician, then clinicians really need to be prepared to have these conversations rather than saying it's not needed for the boys or we don't really know if it's working. Like, those are not the ways to convince hesitant parents to immunize their kids. So I think we have a lot of work to do around training the clinicians, because parents will generally do what the doctor tells them. So that's been our experience with that. Thank you.
Is there a lot of research being done on training the clinicians by developing educational tip sheets or something?
I think
like that?
we're starting to move in that direction. The CDC, anybody who's interested, the CDC has a website, You Are the Key, and you can go there and you can get, there's videos and talking points and all kinds of things for clinicians. I think just sort of putting that stuff up on the website and saying here's a tip sheet and here's a video is probably not enough. I think we really need to do a better job of taking things more directly to the clinicians. So that's what we're hoping to do with our intervention. I think we're moving in that direction, but we're not quite there yet.
this year, I was really concerned about the very low rate for boys vaccination, which is, you know,
Like,
way
wait,
behind where the girls are. And it seems like there must be a common perception that boys don't benefit or don't need it or something like that. But I think 2017 is predicted to be the first year there's more HPV-associated oropharyngeal cancer, which is 3/4 male, 1/4 female,
Right.
than uterine cervical cancer.
right.
So it's, in theory, more cancers will be prevented now in the United States by vaccinating men,
Right.
boys, than
Right.
girls. So should it take a lead in some of these discussions about
Right.
vaccination?
So the challenge, so Del, that's a great question. One of the reasons why the boys are lower than the girls is because their recommendations for routine immunization came later. So we're sort of trying to catch up with the boys. The problem with and I agree with you completely, the problem with the oropharyngeal cancer is that that's not an indication for this vaccine. So the randomized trials that were done looked at cervix, anus, penis, vaginal, and vulvar infections. We do not have, there is no indication, if you go to these talks and the drug companies are there, you can't even talk about oropharyngeal cancer. Of course the vaccine is going to prevent oropharyngeal cancers that are vastly caused by type 16, right? The problem is, clinicians, because it's not an indication, because we don't have data, you're on thin ice. I mean, in my heart, I know it's going to decrease oropharyngeal cancers, but we're kind of in a difficult place talking about it. Does that make sense?
Yeah, there was a recent study, though, that showed a decreased oropharyngeal infection.
Mm-hmm.
So you know, it hasn't really been shown to decrease uterine cervical cancer
No.
either.
Nope.
So it's on a little bit of, if you say it's on thin ice one way, you got to say it's on
Right.
thin ice the other way, I think. So
Right. Well, the study that you're talking about was not the randomized, not the pre-licensure pivotal efficacy trials. So it's not in the package insert. Right. A number of studies are showing decreases in oral infections, but it's not on the package insert. Unfortunately, it probably should change that. We should do something about that. One more question? Yeah.
Do you get questions regarding the new changes that have happened in women's health or the recommendations for pap smears? Because now, you know, women aren't supposed to get pap smears before 21. They don't even test for HPV before 30. And so, you know, the timeline where that's, you know, that stipulation has changed is not accounted for, you know, everyone being essentially vaccinated.
Right. So the question is about cervical cancer screening, which the recommendations have been changing over the past several years, going from annual PAP to PAP every 3 years and no PAPs before age 21. So those guidelines changed, had nothing to do with the vaccine, right? Those guidelines changed because there was the feeling that we were over-detecting HPV infections in young women when most of them will clear on their own. So you're over-detecting, you're over-treating. So totally independent. Because of these vaccines, whether you're vaccinated or not has no bearing on those screening guidelines, right? So people should still be screened, vaccinated or not vaccinated. But it does make a lot of our efforts around monitoring and evaluation difficult, right? So if we're not doing pap smears before 21, you know, now we're immunizing at 11, 12, we're not going to see things till girls in theory are 21. And the boys, we don't screen for boys, so we have less data on them. So we're very mindful of the changes to cervical cancer screening and how it is going to impact our monitoring efforts. But again, currently, the changes had nothing to do with the vaccines, and the vaccines should have nothing to do with how women are screened.
Right, but that's my question, is how if you have, you know, parents who, you know, if you have mothers who are coming in with their girls and they know that the pap smear, you know, have changed and how you're getting, you know, tested and when, you know, when you're saying we really need to get, you know, your child vaccinated, but on the other hand, the GYN world is saying, we're not actually going to test for this because we're finding the body's clearing it. I'm just thinking that may be a barrier, right, to convincing a mother that, yeah, you need to vaccine for this child when a reading GYN is saying it is being cleared.
Yeah, that didn't really emerge in our data. I've not heard that as a concern, either in the literature or in our own work. I have not heard that, but you make a good point. It certainly could happen. I'm not aware of that being a huge barrier, but for some it might be. Okay.
Thank you.
Thank you. Thanks.